Welcome, everyone. Welcome to Perfecting PT. My name is Nate Norr. I'm a doctor of physical therapy, and if this is your first time meeting me, welcome. If you've listened to other episodes in the past, welcome to you as well. As always, I'm happy to have you guys here. Today is a new experience for all of us because it will be my first ever solo episode. So, obviously, if you've read the title or if you just clicked on this randomly, we're going to be talking about lower body biomechanics. And I think it's a topic that is heavily misunderstood with a phrase that is heavily overused. So, welcome. A little nervous myself. I have always found, I've always thought that I'm pretty good at organizing and presenting information. So I guess we'll find out if that's true. To get myself ready, I ate a handful of Sour Patch Kids and put on my newest cologne for a little bit of confidence. So let's get into it. My biggest thing that I would like to go over today is so you actually know what biomechanics even means. It is a phrase, like I said, it's so heavily used. People are like, oh, the body does this because of biomechanics. And you're like, bitch, I guess I didn't. I guess swearing is allowed. Yeah, that being said, who knows where this conversation will go, because I get a little vulgar in sometimes how I express my ideas. So that being said, people will throw out, they're like, oh, it's the body does this because of biomechanics, like this, that, and the other. I'm like, bitch, what do you even know about biomechanics? And then when you try to question people about biomechanics, they don't know. They don't know. And if they do, it's a very, very superficial, like, oh, the body does this. Like, I've never listened to a podcast that ever, like, if it has biomechanics in the title, I listen to it and I'm like, nope, I did not learn anything about biomechanics in any way, shape, or form. So I'm hoping to clear that up. So you hear biomechanics, you're like, I've got an understanding what that means. And in order for us to know kind of why I'm so strongly opinionated on that, I'm going to tell you a little 2-second aside, a little backstory as it is about myself. I was never planning on becoming a physical therapist. From the time I was like 5 years old, I wanted to become an aerospace engineer or a mechanical engineer, and I wanted to design race cars, and I wanted to design roller coasters. And so I would just sit in my room and I would draw these different designed cars, and I would make these keys, and I would design roller coasters. And that was just my thing. And in high school, I opted out of normal high school, and I went to what in Las Vegas is referred to as a magnet high school. I went to ATech, the Mavericks, in case anyone's curious. And I went to a magnet school where I specialized in engineering. So 2 hours every single day, I had engineering courses from the time I was 14 until I graduated. So 9th through 12th grade. And then I was a missionary in Mexico City. And somewhere along the way, people were asking me what I was going to be when I returned from being a missionary. And me and my best friend, we'd been accepted to the same university. I was going to study engineering. And from one day to the next, I can't tell you really what happened. I just stopped telling people that I was going to be an engineer. And I started telling people that I was going to become a physical therapist. And so I have a pretty heavy engineering background. To this day, I work on my car. I've done major repairs on my car. I've rebuilt my engine. And so like mechanics and how things work mechanically is a big part of how I view the world. And coming into PT school, I thought that there was going to be more of an emphasis on how, like, the mechanics of the body and just mechanical principles, and there wasn't. And so I'm hoping to share a little bit about what I know with you in a way that you're like, oh, I feel much more confident addressing the body in the mechanical way. So that being said, in order to discuss biomechanics, we're going to go over some principles of physics and how I think that applies to joints, muscles, tendons, and ligaments within the context of the body as a system. We're going to look at patterns of compensation as well. And depending on how long this goes, I will also go through my assessment process of the lower body. And in case anyone's wondering, lower body, low back, and down. Upper back, rib cage, thoracic, spine, where it meets the low back and down, that's really what we're covering now. But depending on how long it goes, I may make that into a separate episode, because I am finding that people are much more willing to listen if it's not an hour and a half, which, although those are my favorite because we can really get into the nuances and opinions of my guests, not everyone wants to listen to an hour and a half long lecture, quote unquote. So let's start with the definition of biomechanics for anyone wondering. From Britannica, it says, in science, the study of biological systems, particularly their structure and function, using methods derived from mechanics, which is concerned with the effects that forces have on the motion of bodies. From Cambridge, it is the study of physical forces that affect human and animal movement, or the study of these forces. From an anonymous source that I can probably find the citation for if I need to again, it is the study of the structure and function of biological systems by means of the method of mechanics. It is also known as the study of how biological systems move and interact with their environment using physics principles. So, that being said, my little hodgepodge Frankenstein definition is biomechanics looks at how forces are managed by bodily structures to interact with the environment and generate movement. There are a couple things that we have straight before I share what I'm going to share. And there are some principles that have to be accepted in order for any of this to make sense. Number one, we have to accept that the body is subject to mechanical forces and laws. You say, what the freak does that even mean? It means we're talking about physics. The body is subject to the laws of physics, and so are each of its individual tissues. Things don't just like randomly happen. Motion can be predicted, as the outcome of the motion is an accumulation of the various forces produced within the body. Plain and simple. Those forces are compression, tension, torsion, etc. The mechanical changes within the body and mechanical forces placed upon the body have a very real impact, including impacting the various sensory organs that are determining how much and how well the body can move, its perception of pain, and its tolerance of various positions and activities. You may be saying to yourself, well, Nate, duh, it's like, it's freaking obvious. But there's a growing percentage of people in the health and fitness space, as well as in healthcare, who discount the impact of mechanical forces or want to write it off, as well as structural changes, pathoanatomical injuries, by professing what I believe to be an incredibly overhyped and minimally useful biopsychosocial model. I think it's garbage, but we'll talk more about that later. That'll probably be another episode. And if someone listening is a big proponent of the biopsychosocial model, hit me up. I'm always open to, changing my views or adapting my views as I learn more information in the future and better systems. Number two. So number one, the body is subject to mechanical forces and laws, physics. Number two, structure dictates function. This is one of the fundamental truths in all of science, especially biology. And I really think it's just everything in many ways. It's how we understand the many various proteins in the body, the various types of cells in our body, and also as it relates to this conversation, it helps us understand the job and capacity of the various neuromusculoskeletal structures in our body to perform certain tasks. For example, the structure of the quads dictates that it cannot extend the hip. The quads extend the knee, so they straighten out the leg, and a portion of the quads can help flex the hip. The lat, meaning the muscle that attaches, onto our low back for the sake of simplicity, and attaches up to our upper arm, it does not flex the shoulder. And people are like, well, if it's behind you far enough, it can't flex. No. Under normal circumstances, the lat does not flex the shoulder. And the infraspinatus, which is a rotator cuff muscle that helps us rotate our arm outwards, it cannot rotate the arm inwards. That being said, if the mechanical structure of a tissue changes, so will its capacity to perform a given function. Structure changes, function changes, period. Moving on. The body is, number three, the body is a complex system that is made up of many structures. Optimal function of that system would be defined, in my opinion, as each structure being able to perform its designated function perfectly. Since we are discussing mechanics, you can think about it much like the engine on a car. If you own a car, or if you've ever ridden in a car, if all of the parts of the engine are working perfectly, nothing is getting worn out, and the engine is running smoothly without ever breaking down. 4, compensation, which is the big topic that we're going to discuss today, is what occurs when a structure is not performing its designated function well enough for a given task and requires the input from other structures to complete the required outcome or movement. This compensation must come from structures that are capable of contributing to the limitation present, but in doing so, those structures will have to do multiple jobs. Number 5, compensation will result in altered muscle activation patterns, joint movement patterns, and loading strategies that will result in altered forces on and motions of muscles, tendons, ligaments, and joints compared to optimal. The body will do its best to make a pattern as efficient as possible. If compensation goes on for too long, the patterns used will become the default and the tissues involved will undergo changes corresponding to the compensation. And finally, number 6, forces are, we're going to talk about a little bit about forces. Forces are inherently absorbed distal to proximal, which means that if a proximal joint is if a distal joint is unable to manage the force placed upon it, the body will bypass that joint, and whatever force that it does not manage will be transferred up the chain to the next joint. You can think about this as an example. You're like, what does that even mean? If you were to hold a pillow in front of you and someone hits you kind of soft, you're like, nah, didn't even feel anything. If you are holding a pillow in front of you and someone hits you really hard, whatever force the pillow does not absorb and dissipate will be passed into your chest. Okay, force is, now moving from the other direction, force is generated proximal to distal, which means that all motion and force generated distally requires inherent proximal stability equal to the force produced. You can think about this like you would a building. Everything above the building has to be supported by whatever portion of the building is below. If you have a foundation that can support 100 pounds of bricks and windows and whatever, and you put 150 pounds on it, the foundation will collapse. Okay, so much like a building, everything distal, meaning further down the arm or leg, is dependent on whatever is proximal, meaning closer to the torso, being able to support however much force is going to be produced. Now we get to my working definition of compensation. It is what occurs when a structure is not performing its primary function sufficiently well, so the body uses other structures that have a secondary role and can participate in that function to make up for the limitation. This doesn't just occur within muscles. It also occurs within joints, which we may talk about separately because joint mobility, assessing joint mobility, how joints combine their mobility to generate motion may be another conversation. But before we get into the actual patterns of compensation, we're going to talk about a couple principles of physics that I think are particularly relevant. If you happen to remember Newton's 3 laws, we are going to talk about the 3rd law. I think the other 2 are still relevant. They are mechanical laws and they do impact the body, but we're going to talk about the 3rd one. And that law is, for every action, there is an equal and opposite reaction. All that means is that if someone is running and the force into the ground, we talk about like how much stress or force is placed on the body or placed into the ground when we do an action. If someone is running, the common number used is that running puts a force through the body equal to 6 to 7 times their body weight, which means that same force being placed into the ground that can be measured that force is being placed upon the body, and every single ounce of that force is being managed by something. The same goes for the bench press. If someone is benching 250 pounds, that 250 pounds of force is being placed upon the structures of the upper body. And if there is a portion of the upper body that cannot manage the percentage of the load placed upon it, you will either not be able to lift it, you will get injured, or you will not be able. Oh, I already said you can't lift it. Okay. You either won't be able to lift it or you may get injured. Okay. The second physics principle is a concept called impulse. It has a technical definition in case anyone's like, what's the definition, Nate? But for our purposes, it simply defines the relationship between force and time. And I think that it is most easily understood practically when we talk about the example of a car coming to a stop. There are two examples, one of high and one of low impulse, and we'll talk about that right now. So imagine you're in a car going 45 miles an hour and you see that the stoplight ahead turns red. Unless you're a psychopath, which you very well may be. I've ridden with some crazy people, and you brake at the very last second because you're like, oh, it may turn green. It may turn green. Unless you're a psychopath, the likelihood that you're going to gently apply the brakes and kind of coast up to the light is high. That is impulse. That kind of change in momentum, the change in the movement of the car, the change in the force, the change in how you move over time, that is impulse. And in this case, it was comfortable. This nice smooth. You barely even noticed you were stopping. You just kind of came to a stop, very comfortable. The second example, now imagine you're driving 45 miles an hour and this little old lady driving her Buick, 30-year-old car, shouldn't have a license. She pops out in front of you from a side street. You've got to slam on the brakes to avoid a crash. This is also impulse, only this time, oh no. Brief pause, my lights went out. I'm not sure it's recording. There we go. We are back. Sorry about that. Technical difficulties. But that being said, if this little old lady pulls her car out in front of you and you're going 45 miles and you have to slam on the brakes, you know exactly how that feels. Your whole body gets, your whole body gets thrown forward. Stuff falls off the back seat. If you're driving, you have to brace yourself on the steering wheel. Now that's a very high change. So the amount of force being applied on the car, on you guys, in order to stop in that very short amount of time is high. You feel like you kind of get thrown around. Now, imagine a similar example, but for your joints and muscles. Okay, if you have a very short range of motion in which to stop, much like trying to slam on the brakes before you hit the lady. Okay, the force applied to the structures involved will inherently be higher because the body will have less motion, okay, in which to stop. And so there's a less amount of time. Okay, so more force has to be applied over a little bit of time in order to create the same change that a little bit of force over a large amount of time correct. That should have just been a period. First time for all of us people. So again, large force, short time is equal to a little bit of force over a large amount of time. If you have a larger range of motion with which you can stop the body, that will give you more time, and the force applied to any given structure can be lower, just like the car example. Now, I haven't gotten to the actual patterns yet of compensation, but while we're already here, we're going to just include a little example from the leg. Each joint, for the sake of simplicity, we will just say the hip, knee, and ankle. We're going to leave out all the small joints of the foot, the toes, all that stuff. Each of those joints has a normal range of motion that it should be able to move through, and hopefully muscles that are strong enough to move it well. If the ankle suddenly can't dorsiflex, okay, so meaning that the motion of your ankle to pull your toes upwards suddenly drops by half, what happens? The ankle motion is less to absorb forces now. That means that if an action is done that only requires the ankle, so let's say you just are bouncing on your toes with your knees straight, the force on the ankle will have to be greater over that short range of motion, just like the car that had to slam on its brakes. If the action is one that requires the whole leg, like landing from a jump or doing a squat, the body will likely make up for the motion lost at the ankle by making the knee or hip go through greater motion in order to compensate and absorb the force that the ankle has passed on, if necessary, due to its limited range. Okay. Finally, we'll chat muscles. If a muscle is only strong through a shortened range of motion, the muscle will have to apply a great deal of force within that shortened range of motion to manage movement and load. If a muscle is strong throughout its full length, it can efficiently generate force, and the stress on the tissue can be dispersed over a larger amount of time because the joint can move through, because the muscle can produce equal and efficient strength throughout its length. So, hopefully that makes sense. If it doesn't make sense, I think I would be really open to doing like an Ask Me Anything. I know that's kind of popular with podcasts and different social media pages. We may be able to do like an Ask Me Anything related to biomechanics and clear up some questions if people want further clarification, explanations. So now we get to the patterns. In all reality, the patterns should make a lot of sense. Like the likelihood that I tell you this and you're like, wow, that just makes a lot of sense, is hopefully high, because essentially we're looking at muscles' primary and secondary functions up and down the low back and the leg, which we'll refer to as the kinetic chain. And we're going to look at how that affects motion and loading. However, I'll be honest, every person that I explain this to says it's never been told to them like this. So I hope you find it helpful. So patterns of compensation. There are 3 planes of motion. Again, going to motion, physics. There are 3 planes of motion: sagittal, meaning forward and backwards; frontal, meaning side to side; and transverse, meaning rotation. I'll be honest. I got to be honest. I haven't really delineated the rotational compensation patterns in this podcast. As a physical therapist in my setting, which is just general population orthopedics, I find that the most practical and useful compensation patterns to address for injury, pain, and performance are the compensations related to extension and abduction, but especially extension. Most people that I see come in with a variation of these, most people that I see come into the clinic with any variation of these compensations. And once I address them, they almost always regain function and their pain greatly improves or resolves, regardless of how long they've had their issue. So that's why I think this is so useful. It can be used in both chronic and acute issues. Now, does that mean this system is perfect? No. Freak no. I'm 30 years old. Okay. I'm hoping to build and elaborate on this, learn other people's system and make it even better. But that being said, it is good. Like, this system is good. It is useful. And the likelihood that, the likelihood that this will improve your outcomes by adding it to your way of thinking, I think is extremely high. But I don't fix everyone that comes in my door. I don't know everything. So let's start by discussing what I think is important, and it has to do with the low back. I think the low back and low back pain is a greatly misunderstood and mismanaged problem. My boss / mentor, Phil, always says that chronic low back pain is one of the simplest things to treat. And I often see him treat people with chronic low back pain, and within a period, they could have had back pain for 5 or 10 years. Within a period of 3 to 6 weeks, these people with chronic low back pain have no pain. Okay. Again, is it perfect? No. Of course, there are some people to whom that does not apply. But I have found that I have treated people as well, many of them, and they're like, oh, I've had back pain for 30 years. And we start to address these compensations, and they're like, wow, I haven't felt this good in forever. And it doesn't take 6 months of doing deadlifts and low back extensions to make them feel better. It's quite quick. That being said, I think that it's mismanaged. And I think that my boss also says it's super simple to treat because the low back is a dumping ground for other deficits. And therefore, most things don't compensate for issues with the low back. It's more often, in my opinion, the other way around, that the low back is mostly compensating for all of the limitations that are not managed distally, meaning further down the legs. So going back to our kind of principles, force is absorbed distal to proximal. When you step on the ground, the first thing that experiences force is the ankle. The foot and ankle, anything not managed by it will go up to the knee. If not managed by it, will go up to the hip. Not managed by it, will go up to the back. Okay. But then when it comes time to generate force, we look at the core. And I know people are like, well, what's even the definition of the core? For the sake of our purposes, I'm going to say it is the abdomen, the low back, and the pelvis. That needs to be able to adequately stabilize and provide sufficient stability for the motions that want to be produced by the hip, knee, and ankle. So compensation from the lower body, to be clear, can also cause changes in the upper body. But that is a podcast for another time because I have a feeling that people are going to need a few minutes just to wrap their head around and start working on understanding the lower body ones. So we're going to start with extension, the extension compensation patterns, and we're going to start with the hip. In my opinion, the hip is virtually always the problem. Almost always. The primary hip extensor. So I guess let me organize my not organize my thoughts. Let me kind of explain to you how we're gonna do this. We're going to talk about the joint. We're going to talk about the joint motion involved. So the joint motions involved in the extension. We're looking at the hip extension. So we're looking at the back side of the leg. The motions involved are hip extension. So bringing the thigh behind your butt. We're looking at knee flexion, so meaning knee bending. And we're also looking at plantar flexion, or pointing the toes downwards. And that's produced by the calves. So that being said, we're going to go through the joint motion, the muscle that's primarily responsible for that motion, the muscle that is secondarily responsible and therefore compensates for deficits of the primary muscle, and how that kind of cascades up and down the leg. So the primary hip extensor muscle, so the muscle that should be able to pull our leg behind our butt, is the glute max. Going back to our accepted principles, if the glute max is working perfectly, no compensation will be needed under normal circumstances. However, if the glute max is not extending the hip sufficiently, the body will need to compensate if you want the same amount of hip extension to occur, especially in order to produce force. So, quick question for you, and I'll do a brief pause. Which things can assist in hip extension or bringing the leg behind you? Okay, not going to make you wait around all day. There are the two primary ones, in my opinion. The hamstring as well as the lumbar erectors. The hamstring attaches directly to the pelvis, so the bottom of your butt, and then attaches onto your lower leg, so onto your calf. The hamstring directly extends the leg by pulling on the base of the pelvis, while the lumbar erectors extend the low back and pelvis, indirectly extending the leg. We won't get into the compensations that occur above the lumbar spine from added lumbar extension load right now, but we'll talk about it in another episode. Returning to our accepted principles, the hamstring will now have altered load from helping the glutes perform hip extension. The hamstring's primary function is knee flexion or bending the knee, but now it will have to do more work to help with hip extension in addition to flexing the knee. This can often present itself as a hamstring strain or tendinopathy, especially if it's a recurrent injury, as well as chronically tight hamstrings. Continuing the compensation down the chain or down the leg, we get to, okay, so we've already got there. We've already gotten to the knee. Hip, knee, hamstrings kicking in for the glutes when it's not doing its job. So now, what if the hamstring is overwhelmed because it's now doing two jobs? What is the muscle that assists with knee bending? Okay, now we get to the gastrocnemius. So that's the calf muscle, which primarily its job is to point the toes. But since the muscle attaches above the knee as well, it plays a role in knee flexion. The same rationale for the hamstring can be applied here. The gastroc will now be compensating to assist with some knee flexion, reducing its ability to maximize its primary function, which is pointing the toes. And now that we get down to the ankle, we have a few different muscles that will be affected by compensations. Using the principles we discuss, you'll be able to think about additional compensations possible that I may not go over today. So we'll start with the soleus, which assists the gastrocnemius with pointing the toes. But now the gastroc is trying to manage two jobs. The soleus will have a greater responsibility to contribute to plantar flexion. The soleus really has one muscle action because, again, of its structure. Structure determines function. And its structure would dictate that it points the toes only. Now, I know there are people out there thinking that the soleus has additional role when the foot is on the ground, meaning when it's in closed chain, but we're not going to discuss that for the sake of simplicity right now. Needless to say, the soleus is now under additional load and compensating for the gastroc. The other two muscles that are often affected are the tibialis posterior on the inner calf and the peroneals on the outer calf, also known as the fibularis muscles. The tibialis posterior on the inner calf naturally helps pull the foot inwards, but has a secondary role to help with plantar flexion. Okay, so it assists the calf muscles in pointing the toes as well. The peroneals or fibularis muscles on the outside of the calf naturally help pull the foot outwards, but also help with plantar flexion as well. If the gastroc and soleus are under added strain because they are compensating for other limitations up the leg, the tibialis posterior and peroneals will be under greater load to help with plantar flexion, which means they are now trying to provide stability with pulling the ankle in and out, as well as pushing it up and down. So the gastroc, soleus, tibialis posterior, and peroneals' inability to effectively compensate often results in Achilles tendinopathy, plantar fasciitis, shin splints, lateral calf aching and pain, and, as many people often hear, reportedly tight calves. And you may be saying, wow, Nate, this is really helpful information, but how do I use it? Returning to our accepted principles, the body is a system. And in my opinion, we must address it as a system in order to get the best results. Each person's body is different, as well as their movement preferences. But I firmly believe that these patterns are the same, although the location of dysfunction and injury will be unique to the individual based on their strengths and habits. You use the patterns listed to assist in your assessment to recognize the dysfunctions present in the lower body that can be contributing to how the whole body works, and why someone may be injured or dealing with pain and limitations the way that they are. So I'm going to do a quick recap of the hip extension compensation pattern. The glutes are the primary muscle responsible for extending the hips. The hamstrings are a secondary muscle for extending the hips, as well as the lumbar erectors or the low back extensors. If the glutes are inadequately producing hip extension, the low back and the hamstrings will kick in to assist. The hamstring is now, instead of just managing its primary function, which is knee flexion, it's got a little more work to do in helping the glute extend the leg. So it may need help performing its primary motion of bending the knee. And so we get to the gastrocnemius. So it's going to assist in bending the knee. But now it's helping bend the knee. It's trying to manage bending the knee and pointing the toes. So the soleus may take on a greater load to point the toes. If that becomes a problem, and the soleus can't manage that, then we get to the tibialis posterior and the peroneals, both not being able to focus on just their primary roles, which is pulling the ankle in and out, ankle and foot. And now they have to help with plantar flexion as well. If we go into the Okay, I had a brief lapse in my thinking. So I know that we just went through the patterns of compensation down the back of the leg. So working from the bottom, or rather working from the top again, hamstrings and low back compensate for glutes. Calves, gastrocnemius compensates for hamstrings. Soleus compensates to assist. It's going to take more load if the gastroc is doing two jobs. Tibialis posterior and peroneals compensate for soleus and gastroc. So there's a couple things. I'm just going to kind of go off script here for a minute just to point out a couple things. I will have patients come in that are dealing with knee pain on the right. Okay. And I will most definitely, and I definitely think that the knee is overloaded on the right because of a hip dysfunction on the left. Okay. I've also had it where people are coming in for low back pain, and I believe that the reason they're having low back pain is because of an ankle dysfunction. And you may say, Nate, that's the stupidest thing I've ever heard in my entire life. And you are free to say that. But when someone has chronic low back pain and you look at them and you're like, I don't see any reason why you should have back pain the way that you do. And the main thing that they're limited in is an ankle motion or their ability to use an ankle strategy efficiently, and you address that and their pain goes away. I mean, I'm not really sure what your argument is in return. So that being said, when we talk about how force needs to be managed, I'm a big proponent that force needs to be managed equally within the lower body. If you can have a right leg that has pain in the hip, knee, or ankle, and it is obviously stronger and more stable than the left leg with various forms of testing. Okay, why is it therefore in pain? Does it need to be strengthened more? I don't think so. I think that the weak leg is offloading the force it can't manage onto the other leg in the low back. And so something that is really important to me when I address patterns of compensation is symmetry. And I know that there are people who are vehemently against symmetry. But I believe that if each ankle can perform the same functions equally well, each knee can perform the same functions equally well, each hip can perform the same functions equally well, why would the body need to compensate? I don't think it would. If each joint within the chain, hip, knee, ankle, low back, can do their job respectively well, why would something need to compensate for it? If each leg can do it, I don't think anything really breaks down. So things to think about when assessing and looking at these patterns of dysfunction. You may have a hamstring compensating for a left hip. So obviously the left hamstring. The left hamstring is helping out the left hip, and this person is coming into you with right knee pain. Okay, that's why we have to look at the body as a system. If you do not accept that the body is a system, you will not be able to use these patterns of compensation successfully. Okay, you need to make sure that everything from the low back down, I say this frequently with patients, it's like, in my opinion, a problem from the low back down is a problem with everything from the low back down. And someone's going to be like, Nate, that's nociceptive. Well, guess what isn't nociceptive? The fact that they feel better in 2 weeks. So not sure, not really sure how to respond to that. So it's like each joint has an amount of motion it should have. It should have it, and it should be equal to the other side. They could both suck. It's like, that's why it's also important to be aware of norms and not just rely on, it's like, well, both hips extend the same, so the hips aren't a problem. Yeah, but do both hips extend the way that they should based on norms? So a couple things that need to be taken into consideration. Are the joints moving the way they should, both relative to one another on each side? Are they symmetrical? And are they close to how we believe the hip should move based on norms? And carry that down. Knees, ankles, okay? Low back. Now, once we recognize a dysfunction, okay, you have 2 ways to fix it. But I'm realizing right now, and I already know we're at 40 minutes, so for anyone listening, hang on. I realized I did not address the abduction compensation pattern yet. So for anyone listening, the primary muscle that is responsible for abducting or lifting the leg to the outside is the glute medius. You can also say that there is the glute minimus as well, and the TFL. But I believe that the one who should be primarily doing the work is glute med and glute min. When they are not doing their job sufficiently well, you will notice an increase in use of the TFL, as well as an indirect abduction of the leg by an increase in the use of the QL within the low back, which I often find is contributing to low back pain. Okay, if you cannot, from there, secondary muscles that also assist in abduction, okay, we get to the piriformis, we get to the sartorius, we get the upper fibers of the glute max, okay, we get the QLs and the lumbar erectors, and we also get, if you are someone who believes in anatomy trains or fascial connections, we also get the peroneals. We also get the peroneals to help lift the leg if the leg is not on anything. And we also get the tib posterior as well as the adductors across the knee that compensate if there is, if the foot is on the ground. So just in case anyone's like, what the freak did Nate just say? I will delineate it one more time. Glute med should be primarily responsible for abducting the hip, okay, and keeping the knee and the ankle, okay, in line with one another from its proximal position. If it is not, you will offload load onto the TFL, the QL, and the lumbar erectors. You will also find increased load on the piriformis and the upper fibers of the glute max. Okay, and that's kind of right around the hip. As you get down, the adductors that cross the knee will also assist with closed chain abduction stability. And if it is, as well as the tibialis posterior, because it will try to correct for what the glute med cannot do to abduct by overcorrecting with the ankle. And in open chain, you have the peroneals. Okay. So once you recognize the dysfunction through your assessment, you can fix it one of 2 ways. The first is to strengthen the area of dysfunction in order to bolster its ability to compensate and handle greater strain. This is a common choice I see among clinicians, particularly younger clinicians, and I'm including everyone that is under 40 in the younger clinicians category. It is generally, this option of just trying to strengthen a dysfunction is generally less complicated and can still provide patients with some relief, if not really good relief. It is particularly popular amongst those who have a strength and conditioning background. The important thing to remember is that the load and motion has to be done by something. And strengthening a dysfunction without addressing other contributing areas could impact the various tissues of the leg and the joint where you find the dysfunction most prominently in negative ways. It's also important to realize that this is why people will not have pain despite obvious compensation patterns. If one of the muscles listed in the chain is strong enough to manage multiple jobs, the compensation may not propagate down the chain, or the body may simply be able to manage it without discomfort. But in my opinion, it's likely that the dysfunctions still present are impacting the body in ways not obvious to the person at the moment. Okay, if anyone has listened to my previous conversation with Jared Countess, also known as Professor Corrective on Instagram, you may be able to ride that tissue or put it under greater strain for 10,000 reps. But at 10,001, it may decide that it's no longer going to tolerate how you've been loading it, and it may either fail by tearing, breaking, or you may begin to develop other degenerative issues or chronic overloading issues like tendinopathies, arthritis, arthrosis, and other changes that the body does not like. Now, the other option, if you aren't just going to strengthen a dysfunction so that it can be managed, and I think this is the best option, is to address the body as a system, clean up the mechanical changes in range of motion and the ability for a muscle to perform its primary function optimally throughout the low body. Okay, the drawback for this option is that it requires in-depth knowledge and skill with strength and conditioning principles combined with neuromechanics and manual techniques to achieve the best outcomes that last without recurrence. This requires a great deal of time and the help of a truly skilled mentor. And I'm going to be honest, I don't think there are that many out there, despite what people say. For those of you listening right now that are either frustrated or overwhelmed because you either disagree with me or feel that you don't have someone in your life to help you learn how to address these problems well, let me be clear. I believe that strengthening is a good thing. And it is always, well, it's not always necessary to get someone out of pain, but I believe it is always necessary to optimize someone's function and improve their lives. So if that's what you're comfortable and competent with, you will still be able to help lots of people. Okay. But as far as the highest level of skilled physical therapy goes, I believe addressing compensations at their root and optimizing the body as a system is best. You will often find, or, if you're not someone who does this, I often find that when I do this, I find that a lot of people really don't need to be stronger. Like they may not even need to do strengthening, okay, to get out of pain and return to their normal activity. That doesn't mean that I do not promote strengthening. I do. Big fan. Okay. Because once compensations are addressed and the body is focusing in what is, as best as they can, because each best will be dependent on the person, you need to reinforce those best patterns so that they can move in various ways and get into different positions without breaking down into these compensations again. So real quick, we're going to go into just some common cases that I deal with. And, just to kind of sum up how it may be relevant. Okay. So I often find that the most important issue to address, like I've already said, is extension and abduction limitations, but particularly in the hip. Okay. I think this is caused by poor glute activation and control. So someone's screaming at their radio right now. Laptop, headphones, shaking their head. Someone is pissed right now because I said glute activation and control. And my response is simply going to be, riddle me this. How is it that someone that can hip thrust 3 plates can't lift their damn leg off the table when they're laying on their stomach without arching their back like they're in a Tate McRae music video? Riddle me that. It's like, and this is the problem. It's not just about strength. Just because you can deadlift 500 pounds does not mean that you have good hips. Just because you can dunk does not mean you have good knees and ankles. Like, and that's what I mean. Like, people come to me all the time because they've seen other therapists, trainers, chiropractors, and the person's like, I can deadlift 5 plates. I don't understand why I have back pain. And we will address the hips because their hip extension invariably sucks. And then suddenly they come back 2 weeks later and they're like, I feel great. And I'm like, yeah, that's because your back isn't overloaded and doing all the work. You have regained mobility and control of the hip that you didn't have before, and it offloads the spine from handling all the crap you were doing. And all the previous advice they've been getting of, well, you just got to drop the weight a little bit. Pain, you can work through pain. Pain doesn't mean damage. Like, you just got to, start at 315 and work your way back up over the next few months. All of that was useless. Because if they would have simply addressed the biomechanical limitations in the first place, meaning, is the hip doing what the hip should do? Because if it isn't, it's going to offload stresses onto other structures around it. Problem could have been solved sooner. So that being said, from what we've discussed, we know, so let's talk about chronic low back pain. We'll talk about chronic low back pain, and we will talk about Achilles tendonitis and plantar fasciitis. Talking about chronic low back pain, from what we discussed, we know that the low back erectors will extend more to help with hip limitations, and the hamstrings will tighten up as well. And if the low back erectors are chronically overworking, the load on the lumbar spine into extension will be increased, and over time, it may become sensitized. Once we address the hip extension, mobility, strength, and control, the added load on the back that it does not like will be removed, and the symptoms will likely improve or resolve without ever having to do strengthening specific to the low back. Just like the example that I already kind of went on a tangent to explain. Another common thing that I see is people with Achilles tendinopathy or plantar fasciitis. If their ankle function appears normal through testing, but their hips have poor extension, poor abduction, poor strength, or their knee flexion sucks, it's likely that down the chain, the plantar flexors are attempting to compensate and have began to break down or become sensitized. Okay, so going from that before, it's not that I don't think people should do heavy isometrics to improve the health of the tendon. It's not that I don't think people should do ankle-specific interventions. But it could be that someone has a tendinopathy or plantar fasciitis because it's managing too much load that is not being managed well by the hip. Okay? Because again, I've seen numerous people that they've come in with plantar fasciitis that they've had for years. I see it a lot in nurses. I see it a lot in runners. I see it a lot in older people, especially that have feet pain. And you'd be amazed how often people will come in. I will start with some hip isometrics, specifically some hook lying abduction and adduction isos. I start with 10 of 10 seconds because it's simple to remember, as well as maybe some like posterior pelvic tilt glute bridge isometrics, 10 of 10 seconds. And they've had plantar fasciitis for a year. And they may come back within a week and say that their pain is either greatly improved or gone. So what I'm trying to get at in wanting to present some information about patterns of compensation that I think is important is sometimes the area that is undergoing pain is because it is compensating for limited mobility, strength, and control elsewhere in the lower body. And because we are constantly on our feet, it may not even be a limitation within their same limb. It may not even be on their same leg. It may be their opposite leg. Okay? We need to look for limitations present in all of the lower body, particularly the hip, and begin to address them with the interventions. Sorry, my light went out again, but we're only going to be here for a minute, so we'll just let it ride. You need to intervene in ways that you are comfortable and qualified to do to address those. And I think you'll be surprised at how much better your patients or clients feel, how much longer they notice that they feel better. And I think you will start to develop a better understanding of how the body works. And you will become a truly skilled clinician that isn't just doing strength and conditioning disguised as physical therapy, because that is one of my biggest pet peeves. So guys, thank you so much. If this did not come across as clean as either one of us were hoping, okay, I am more than happy to answer questions. You can shoot me DMs, you can shoot me emails. My email is perfectingpt@gmail.com. Instagram is perfectingpt. Happy to respond to any questions, connect, talk about patient cases. But I knew that if I didn't just sit down and try to get this information out, I would be sitting at home on my laptop, constantly tweaking something here or there forever. And I wouldn't, you wouldn't get the chance to know a little bit more about what I did or about what I think and what I do. So thank you guys for listening. As always, happy to have you here. And if you've made it this far, please consider hitting the subscribe button. I don't send out stupid letters. I don't send out email letters. If you subscribe, you're not going to get ads from me. Realistically, if you follow my Instagram page or subscribe to the Spotify podcast, all you'll do is get notifications when new episodes come out, which is every first and third Monday. But anyways, guys, thank you so much again for being here. I'm Nathan Norr, Doctor of Physical Therapy. This has been Perfecting PT, first ever solo podcast. Thanks for sticking it out with me. And as always, happy to have you here.